Good morning, everyone. Welcome to our meeting. We're lucky to have Dr. Tilley talking to us today from Donald Gordon, instead of critical care there, on a very important and I think useful topic for all of us. Something I don't think we understand very well, and really looking forward to getting a bit of guidance from Dr. Tilley.
Morning. We're going to talk about inotropes and vasopressors today. It's just a basic overview so that you've got some understanding on how to approach the use of these medications. Is it the sideways arrow? Just click here. How do I start? Oh, there you go. All right, just a quick reminder about shock. The shock is a common reason for admission to ICU, and if you do get admitted to ICU with shock, it's not generally a good thing. So overall, there's about a 20% of ICU deaths are related to shock. And if you need vasopressors for your shock, it's even worse. Up to 50% of those patients die regardless of the etiology. So the first thing that's important to understand is how you become shocked. So you become shocked in one of two ways. You either drop your systemic vascular resistance, and this is the typical situation that you see in patients who are septic. This is the most common cause of shock overall, but there are also other reasons as to why you may have a low systemic vascular resistance, such as spinal cord injuries, which result in neurogenic shock, or you can drop your cardiac output. And if you remember the equation for cardiac output, it's your heart rate times your stroke volume. A low heart rate is an uncommon cause of shock, but it is a possible cause. Most patients will cope even with severe bradycardias, but it's a potential cause of shock. But it's really the low stroke volume that can cause shock, and the stroke volume is dependent on your contractility, which can be poor if you've got a problem with your heart, such as a myocardial infarction with cardiogenic shock, or you can have a low preload. And the preload can be low either because you're volume depleted, such as you're hypovolemic or you bled, or because you've got an obstruction which hinders the return of blood to the heart. And those ones would really include things such as tension pneumothoraces, which increase the pressure in the chest and decrease your venous return, or pressure on the heart, such as with a constrictive pericarditis and acute tamponade. So just to go over the basic targets in shock, in ICU, we prefer the concept of a mean arterial pressure. Generally speaking, systolic and diastolic blood pressures are not of much importance in ICU. We would prefer patients to be managed according to a mean arterial pressure. Generally, the mean arterial pressure is about 65 plus that we need. There have been a few trials looking at whether higher mean arterial pressures improve outcomes in patients. They generally don't. So if you increase your mean arterial pressure, you may have better outcomes in a subgroup of patients. So a subgroup really would be young patients and patients that are hypertensive at home and are used to higher blood pressures. But in general, if you run your patients at higher mean arterial pressures, you have increased cardiovascular complications without much improvement with that. The mean arterial pressure is an important thing to recognize, because often what you'll see with patients who are shocked is that the systolic blood pressures would be low, the diastolic blood pressures would be high in some cases of shock. So although the systolic over diastolic pressures would look alarming, the mean pressures would often be okay. Or you would have a good systolic pressure, such as in septic patients with a very low diastolic pressure, and that would give a systolic over diastolic, which doesn't look that bad, but your mean pressures are not good. So the mean pressure really is just the way to go. Organ perfusion is another way to have a look at what our target is. We generally want a urine output of 0.5 milliliter per kilogram per hour. Lactate is important as well. So when we treat patients for shock, we would like to see that the lactate at least stabilizes in patients and ideally starts returning to a baseline. And then mixed venous saturation. You would remember that you've got arterial blood, which goes up from the heart, which is usually well oxygenated with a saturation of, say, 95%. This blood circulates around the body into the venous system. When you get to the venous system, obviously the saturation is lower. Any idea where you are normally with your saturation in your venous system? Yeah, about 70–75%. So generally the lungs just have to go from about 75% to 95%. And what you find is as patients become shocked, there's an increased peripheral extraction of oxygen. And this decreases the amount of blood in your venous system. So your mixed venous saturation drops. And there was a lot of excitement about 15 or 20 years ago about resuscitating patients to a normal mixed venous saturation. The data, unfortunately, for that, as in almost all things in ICU, turned out to be a lot less exciting as time went on. So just a reminder of the receptors. This is the traditional way that you are taught in physiology. So we've got adrenergic receptors. Just as a rule of thumb, the 1 receptors are excitatory or agitatory receptors, and number 2 receptors are ones that relax. So alpha-1 receptors are found mainly, this is now in the context of your cardiovascular system, are found on smooth muscle cells, and they cause vasoconstriction. Alpha-2 have a negative feedback on noradrenaline. Beta-1 receptors are found in the heart. They increase all parts of cardiac function. They increase your contractility, which is called inotropy. They increase your heart rate, which is called chronotropy. And they increase the conduction through your heart, which is called dromotropy. And then beta-2 receptors are found on blood vessels, and they cause relaxation of the blood vessels. This is often an interesting thing that I note when we get the students coming through, because you ask them what happens to patients when you give a beta blocker, and what happens to your blood vessels when you give a beta blocker. Yes. You can either relax or you can contract. You've got a 50% chance of being right. So if you give a beta blocker to a patient, what would happen is that the beta receptor, which causes the blood vessel to relax, would be blocked, and you would have unopposed alpha receptors on the blood vessel. So beta blockers cause vasoconstriction. So certainly the way that propranolol decreases your blood pressure is not by relaxing your blood vessels. And there's also a reason why propranolol is not a good medication to take if you've got heart failure, because in patients with heart failure, they're already vasoconstricted from their failure, and it's not a good drug. You remember, not to go off on a tangent too much, but if you remember that we get different types of beta blockers. So the one group of beta blockers are selective beta blockers, which are selective for beta-1 receptors. And those beta blockers are medications such as tenolol, which is beta-1 receptor, beta-1 selective. So is bisoprolol, is beta-1 selective. Then you get the non-selective beta blockers, such as propranolol. And then the new generation beta blockers, which are also non-selective, such as carvedilol and metoprolol, but they also have alpha blocking effects. So the effect on the blood vessels are more neutral. And there's also been, I mean, as a matter of interest, there's also been some work done about using beta blockers in patients with septic shock, which would seem initially. So it would seem counterintuitive to give a patient who's septic and hypotensive a beta blocker, but one understands why that would work. That if a patient is peripherally vasodilated and you block the beta receptors, one would expect a vasoconstriction. And you know, there is some data that this may be a useful strategy, although it's never come to being clinically useful. Another receptor that's important is vasopressin receptors. And I think that we don't pay enough attention to vasopressin receptors. Vasopressin receptors are very important in maintaining blood pressure. So there are 2 receptors. There's a V1 and a V2 receptor. The V1 receptor is found in vascular beds. They're in fact more ubiquitous than alpha receptors. And importantly, they're also found not in the pulmonary vasculature. And this becomes important because sometimes when we choose a medication, we don't want to get pulmonary vasoconstriction, and stimulation of V1 receptors would be a useful strategy in that regard. V2 receptors are an entirely different thing. They're found in the kidney, they result in the insertion of aquaporins in your collecting tubule, and they've got an antidiuretic effect. So just a reminder about the pressins. So vasopressin is a naturally occurring peptide and is produced in the posterior pituitary. Terlipressin is a synthetic analog of vasopressin. I don't know if you've got terlipressin. You've got terlipressin available. Terlipressin is generally widely available at the moment. It functions very similar to vasopressin. The advantage that terlipressin has over vasopressin is that it's much longer half-life. So if you dose terlipressin, you can dose it usually as a stat dose 3 times a day or 4 times a day, depending on how much you need. And then desmopressin, which is also a synthetic analog of vasopressin, has got very high selectivity of your V2 receptor. So it doesn't do much in terms of a pressure effect, and we know that is useful in patients with platelet dysfunction by releasing von Willebrand's factor from your endothelium. Then there are some other ways that medicines can cause vasoconstriction. Methylene blue is a very potent vasoconstrictor. I don't know if you know that, by decreasing the production of nitric oxide. And molrenone has sort of got a niche place in the management of some patients. It's a phosphodiesterase inhibitor, so it decreases the catabolism of CAMP, and that eventually results in increased calcium, and it mimics a beta-1 and a beta-2 receptor activation. So from that, one can deduce if you're stimulating beta-1 and beta-2 receptors, it would cause increased contractility in your heart, and it will cause vasodilation of your blood vessels, and that is useful in some patients. All right, if you have a look at the drugs and where they work. So a drug that you are all familiar with, dobutamine. So dobutamine is mainly a beta-1 agonist. It's got a strong action on the heart. It increases contractility. And then it's got a mixed effect on the blood vessel. So it acts on both alpha and beta receptors, slightly more beta receptor activity than alpha receptors. So overall, you would find that the dobutamine has got a neutral effect on your systemic vascular resistance. And this is why we use it in heart failure. So it's a very designed drug. The idea with dobutamine is that you would want to increase cardiac contractility without increasing the overall work of the heart. And the way that we don't increase the work of the heart is by not causing a tachycardia and by not increasing the afterload of the left ventricle. As you start increasing the doses of dobutamine, the contractility of the heart starts increasing, and then you do start getting into a place where you increase the myocardial oxygen demand. So in fact, I'm sure you know the sort of the common cutoffs of dobutamine. So it would be sort of up to 10, 15 mics. And the way that we got to 10 or 15 mics of dobutamine in heart failure is by looking at when most patients become tachycardic. So generally patients won't become tachycardic between 5 and 10 mics of dobutamine. Above 10 mics, patients become tachycardic, and then the myocardial work starts increasing, and then you start getting into a bad territory. Adrenaline is a lover of all receptors. It stimulates the heart, it stimulates alpha receptors, it stimulates beta receptors, beta-2 receptors. In fact, the affinity of adrenaline for alpha receptors, remember alpha receptors cause vasoconstriction. The affinity of adrenaline for alpha receptors is strong, probably stronger than that of noradrenaline, which is the prototypical alpha receptor agonist. If you look at the table there, what do you think adrenaline does to your peripheral vascular resistance? It's counterintuitive. You've got alpha receptors, you've got beta receptors, you're stimulating both your alpha and your beta receptor. The alpha receptor activity is mainly at high dose that you get. So at first sight, the way that we are taught, we're taught that adrenaline is a vasoconstrictor. It's in fact not a vasoconstrictor, it's a vasodilator, because at lower dose, in the doses that we usually use, it is a more prominent beta agonist than it is an alpha agonist. So low dose adrenaline will increase your contractility. It will drop your systemic vascular resistance. It acts in a manner which is very similar to dobutamine. If you go to high dose, the situation changes fairly dramatically. Noradrenaline is the other way around. Noradrenaline is for all intents and purposes a strong alpha agonist, so it's a very strong vasoconstrictor. At high doses, it starts getting some beta-1 activity, so it will start stimulating your heart. And it also starts getting some beta-2 activity. So what you'll find is that if you look at the vasoconstriction that you get with noradrenaline, it will increase in a linear fashion up to a point where you start stimulating your beta-2 receptors, and then you'll start seeing some dilatation come in at that stage. Phenylephrine is a pure alpha-1 agonist, so it's a pure vasoconstrictor, as is vasopressin. Vasopressin works on the V1 receptor. It's not an alpha-1 as the table indicates, but for intents and purposes, you can see it's a pure constrictor. And then, as we said, that molnupiravir acts on beta-1 and beta-2 receptors, so it will cause increased contractility and vasoconstriction. So if we then look at the overall effect, so dobutamine will increase your cardiac output, it will drop your systemic vascular resistance, and then depending on how that pans out, your blood pressure, your MAP may either increase, decrease, or stay the same. Adrenaline will increase your cardiac output very dramatically. It will either increase or decrease your systemic vascular resistance, depending on how much you're giving, but it will increase your MAP. And really, the important thing to understand about adrenaline is that adrenaline mostly functions about increasing cardiac output. So almost all of the effect that you see from adrenaline is by an increased cardiac output, and the increases in cardiac output is fairly dramatic. I mean, you can increase your cardiac output by 60–70% on a reasonable dose of adrenaline. Noradrenaline, well, the main thing there is that it will increase your systemic vascular resistance dramatically, and then it will either increase or decrease your cardiac output, depending on where you are. If you've got high dose noradrenaline, it will stimulate your beta-1 receptors, will increase your contractility. If you've got low dose noradrenaline, then you would expect some drop in your cardiac output as your systemic vascular resistance increases and it clamps down on that. Phenylephrine will drop your cardiac output, increase your systemic vascular resistance. So will vasopressin, and then molnupiravir will drop your systemic vascular resistance from its beta-2 effect. All right, so that is the traditional way of teaching these medications, which is, if you're not very familiar with them, terribly confusing, and I'm sure you are now thoroughly bored and thinking, oh my God, where are we going with this? So we would like to just introduce a different way of thinking about these medications that is a more clinically appropriate way. So when we look at inotropes and vasopressors, we really need to have a look and see what is it that you want to do. So you need to have some idea of what is wrong with your patient, and then you pick the medication that is appropriate for that. So if you want a pure vasoconstrictor, then phenylephrine and vasopressin are your two choices there. Those are the two medications that are pure vasoconstrictors. And sometimes you do want a pure vasoconstrictor. So in patients that have, say, for instance, an epidural placed and are vasoplegic from that, those patients would benefit from a pure vasoconstrictor. Other than those situations, it's not a terribly useful drug to have a pure vasoconstrictor. Pure vasodilators would be nitroprussate and nitroglycerine. Just to remember that people are always very keen on nitroglycerine as a vasodilator. We remember when we talk about vasodilator, we're not saying an arterial dilator or a venodilator. We're just meaning the vascular beds in whole. And it's an important thing to understand that these drugs work both on veins and on arteries. And we all have a romantic idea that when you give a patient nitroglycerine, the nitroglycerine goes into your heart and it soothes your coronary arteries and it causes vasodilation of your coronary blood vessels and therefore decreases your symptoms and your angina. But that's probably not how nitroglycerine works. Generally speaking, you would need very high doses of nitroglycerine to cause arterial dilation. So nitroglycerine is probably more a venodilator. And venodilation is useful in cardiac patients because if you dilate your veins in your body, then what follows? Your preload will decrease. As your preload decreases, your cardiac output will decrease. As your cardiac output decreases, then your amount of work that your heart does decreases. So nitroglycerin certainly does decrease your myocardial work and then decreases your angina in that manner. It doesn't do what we would hope it does and dilate your coronary arteries. It certainly will do that at very high doses. It makes nitroglycerin a useful drug in patients where you have a fluid problem, such as patients who have fluid-dependent hypertension. So say you have a patient who's markedly fluid overloaded and you have difficulty getting fluid off, the nitroglycerin could be useful if the patient is hypertensive by dilating your splanchnic bed and storing the fluid there for now. But really in ICU, the two groups that are of interest to us are those that are of inotropic effect, and then either vasoconstricting or vasodilating. So we've got the inoconstrictors, and those are the ones who've got an inotropic effect and are constricting. And really the options there is noradrenaline. That's the poster child of that group, and then adrenaline, but in high doses. And the inodilators would be adrenaline, that would be in a low dose, dobutamine and milrinone. So we then need to decide what we want to do for the patient, and we pick the drug according to that. So just to show you a picture from a study from the 60s when much of this research was done, you can see at the bottom there your systemic vascular resistance, and you can see how nicely adrenaline drops your systemic vascular resistance, unlike noradrenaline, which is the first slide. But you can see a raise in your MAP with both of the medications. The MAP from adrenaline, as you can see on the top there, is entirely dependent on an increase in your pulse rate, cardiac contractility, and your cardiac output. It's a foreign concept that in most patients that adrenaline is a venodilator. I think that this is a useful presentation of a representation of how to pick a medicament. So we've got vasoconstriction at the top and we've got vasodilation at the bottom. So firstly, if we look at our pure agents at the bottom, we've got nitroprusside, which I'm not even sure we've got available. Do you still get nitroprusside? Not really. Nitroprusside is a pure vasodilator. In terms of pure vasoconstriction, your strongest vasoconstrictor is phenylephrine, and slightly less than that is vasopressin. They are pure vasoconstrictors. You'll see that low dose noradrenaline, and by low dose we mean less than 0.5, which is a fair amount of noradrenaline, but less than 0.5. Low dose noradrenaline basically is, for all intents and purposes, phenylephrine. So they are very similar in their clinical efficacy. If we look at adrenaline, low dose adrenaline, and low dose we mean less than 0.5, it's got little effect on your blood vessels, to slightly vasodilatory in some patients, but it's got your inotropic effect. Dobutamine will do a very similar thing, but it's more vasodilatory. And then when you start going with high doses, high dose adrenaline and high dose noradrenaline start approaching each other, and they act in very much the same way. They become indistinguishable from each other in that dosing range. So the first thing to know when we start looking at the clinical application of these medications is that no good trial has shown that any medication is better than any other medication, except for dopamine. There's no role for dopamine for anything anymore in any situation. So dopamine has got no reason to exist. In 2024, we will not talk about it on any of the slides. If you are writing up dopamine for a patient, you are doing the wrong thing. Using dopamine is an expedition in the dark. You never know where you are with anything. Also, another myth that we would like to try and get rid of is there's no such thing as renal dose dobutamine. So if that could come to an end, it would be nice. There's also a concept of renal dose dopamine, which also doesn't exist. So dobutamine, we don't start dobutamine to improve kidney perfusion, please. So if we look at the inoconstrictors, which would be adrenaline and high dose adrenaline and noradrenaline, really the place to use these would be in septic shock. If you think about septic shock, you get vasodilatation. You get vasodilatation on both sides of the heart, so you get relaxation of your arteries, which results in a low systemic vascular resistance. You get a relaxation of the veins, which results in a decrease in your preload. So if you can constrict these blood vessels, then on the venous side, as you constrict your veins, it will push more blood back into your heart. It will increase your preload, so that is useful for us. Also, if you think about it, if you were to have a septic patient and the patient has got a very relaxed venous system, and you were to add fluids into a very relaxed venous system, what do you think would be the ultimate effect? Generally, it's not going to be very dramatic because your capacitance of your venous system can be quite vast. So you would just be pouring fluid into a big store in the venous system. Whereas if you can tighten the veins, you can push some of the blood back to the heart. Now, if you've got a bit of tone in your venous system, if you're giving the patient some fluid into that scenario, you'll often find that the patient would be a lot more fluid responsive in those cases. This is a concept that is started in children with hypovolemic shock. It would not make sense in patients who are hypovolemic to give patients inotropes. You would think that if patients are hypovolemic, the therapy of choice would be fluids, and you are correct. This is not including trauma. Trauma is an entirely different situation. We're just talking about normal hypovolemia. So you would be correct that fluids are the primary mainstay of treatment. But the question really would be whether there would be any benefit in adding inotropes or pressors to patients who are dehydrated or fluid dependent or hypovolemic. And the answer to that is yes. So the initial trials were done in children. So what they did is they started just with fluid therapy, or then fluid therapy plus early addition of pressors. And the answer was clear that the combination was better than just fluid therapy by itself. The same is now available in adults. So don't forget the venous system. It's not just the arterial system. But in trials, which is unfortunately what we all have to come back to, as much as we would like to think that theoretically speaking, noradrenaline is the drug of choice in patients in septic shock, the trials have not borne out that there's a dramatic difference between the outcomes in patients using adrenaline or noradrenaline, and either are acceptable. Noradrenaline plus dobutamine will get you to the same as adrenaline monotherapy. If we just go back to this slide, if you take noradrenaline and you add dobutamine to it, you'll see you basically drop your systemic vascular resistance to a certain extent. You'll add inotropy to it, and you'll get then back to a place which is very similar to adrenaline. So then either would be adrenaline monotherapy or noradrenaline plus dobutamine in septic shock. All right, the vasoconstrictors, the pure vasoconstrictors, phenylephrine and vasopressin. The problem with these medications is that by design, their ability to increase your blood pressure is limited, because what happens is that when you give a patient a pure vasoconstrictor, you increase your systemic vascular resistance, and then what happens is you get a reflex bradycardia. So from phenol, you get a bradycardia just purely because of your increased vascular resistance. Vasopressin may also act in the brain by binding B1 receptors in the brain and in causing a bradycardia in that fashion. So they then drop your heart rate, and as you remember, your cardiac output is heart rate times stroke volume, and we're all obsessed with the stroke volume in cardiac output. But if your heart rate goes from 100 to 40, your blood pressure is going to go down in a patient who's compromised. And because of that, their ability to maintain high cardiac outputs becomes limited. So really the place for them is for phenol. There's probably almost no place for phenol either. So phenol is probably useful for patients who go to theatre. and become a bit vasoplegic from an epidural. The nice thing about phenol is that unlike adrenaline and noradrenaline, which has got a 2 to 3 minute half-life, phenol hangs around a little bit. So if you give somebody a phenol bolus, it would hang around for about 20 or 30 minutes. So, you know, you can bolus a patient and hope that they'll settle down from there. So that's probably the place for phenol. In terms of phenol use in sepsis, the United States, I think it was sort of around about 2019, for some reason ran out of noradrenaline. It's not just here. So they then had to switch to phenol as their pressor of choice, because they don't like adrenaline for reasons unclear to anyone. And there was a very definite increase in mortality in patients with sepsis. So phenol is not an appropriate drug for patients in septic shock. And phenol probably is tending towards that category, that if you're using phenol, you're doing the wrong thing. Vasopressin, though, is a useful medication. And there's some data that when you get septic, your vasopressin stores in your brain become depleted. And your baseline vasopressin levels in your body, which maintain vascular tone, becomes insufficient. And there's been a lot of work done on adding a baseline infusion. So we don't dose vasopressin to increase your blood pressure the way that we dose adrenaline in a stepwise fashion to maintain a MAP. We dose it as a baseline infusion, and practically it's a very useful medication. It allows us to use much lower doses of the other drugs. And I think that there certainly is a role for add-on vasopressin therapy in these patients. Once again, unfortunately, the data for vasopressin in that scenario is not great. All right, adrenaline. There's the clear indications for adrenaline. The first one is anaphylaxis. Remember, with anaphylaxis, it's not just a blood pressure problem; it's also an airway problem. So we need to have broad beta receptor stimulation. So something like a noradrenaline is not going to be useful for you in anaphylaxis. The treatment of anaphylaxis, as I hope everyone knows, is 1 milligram of adrenaline into a large muscle, hopefully the thigh. That would be the easiest. We don't give the adrenaline intravenously, and the reason for that is that you get a very rapid peak, so the patient becomes very tachycardic, they start feeling very diaphoretic, and then it wears off very quickly, whereas an intramuscular adrenaline has got a more gradual onset and a more sustained release. Generally, most patients will settle after a single dose of adrenaline intramuscularly. Some patients will relapse, and those are patients that may require adrenaline infusions, but please don't treat anaphylaxis with intravenous adrenaline boluses. And in cardiac arrest, it's clear that adrenaline is the drug of choice in cardiac arrest. There have been some attempts to use vasopressin in cardiac arrest. The trials on that also have not been where we would want them to be. So we're still clear that adrenaline is our drug of choice in that scenario. We've talked about that. I don't know why that is there again. Sorry. Cardiogenic shock. Cardiogenic shock is somewhat counterintuitive. So many trials done about patients with massive myocardial infarctions. The first one was done in the early, it must be the late 90s, early 2000s, called the SHOCK trial. And this showed us an interesting thing. So one would think that when you have cardiogenic shock, that your cardiac output decreases and that the patient will have a high systemic vascular resistance. And the conundrum then came that in these patients, people would often insert intra-aortic balloon pumps to decrease your afterload. And some patients just did very poorly in that regard. And what the SHOCK trial then came out and showed was that some patients that have a massive infarct actually become peripherally vasodilated. They act like septic patients. And it's a fair proportion of that. And obviously, if you are peripherally vasodilated, and you put in an intra-aortic balloon pump to further drop your systemic vascular resistance, then you will do particularly badly, which is what the trial showed us. But be that as it may, the drug of choice generally across the board for patients in cardiogenic shock is noradrenaline. This wouldn't make intuitive sense initially, because you would think that if you have got a poor cardiac output and a high systemic vascular resistance, then adding a medication that causes more systemic vascular resistance would not help you. But the data is strong for it in that regard. So certainly the European recommendation is that noradrenaline is the drug of choice in patients in cardiogenic shock. The Americans are unfortunately still on about dopamine, as in even today the American Heart Association's recommendation is dopamine. I can't understand that. This is not in patients who are in a compromised state. These are patients who are shocked. In other words, you've got a mean arterial pressure less than 65. So don't give somebody who's had a myocardial infarction with a reasonable blood pressure noradrenaline. That's not going to help the situation. If you add dobutamine to that, that will increase the contractility and help in that regard. Obstructive shock in pulmonary embolus, once again, it's more important to get the blood pressure up than anything else. Just to note that if you are obstructed, there's no good drug that's going to make a difference for that. The treatment of being obstructed is to unobstruct you. So if you've got a pulmonary embolus, the patient either needs thrombolysis, either systemic thrombolysis or catheter-directed thrombolysis. As an add-on to that, one can add vasopressin. Vasopressin makes sense in this regard. So what one wants to do in a patient with massive pulmonary embolism is that you often have a high resistance in your pulmonary arteries. You have a failing right ventricle. So you want to have a drug that is going to be neutral in terms of your pulmonary pressures. And the two drugs that are neutral in terms of pulmonary pressures is vasopressin and dobutamine. So the idea with a combination is that noradrenaline can get your systemic pressures up, so it can improve your perfusion to your heart. That vasopressin will add to that, but have a neutral effect on your pulmonary arteries, and dobutamine will improve your right ventricular contractility. But having said that, you're not going to fix obstructive shock like this with medication. If you don't come with thrombolysis, then obviously the next step would be VA ECMO. So just sort of a flow chart to help you think about undifferentiated shock is that one would initiate a noradrenaline on patients. From that, then you would decide if the patients are warm or cold. If a patient is cold, then it usually means that the SVR is very high, and that we would want to then approach increasing your contractility in your cardiac output. And we can do that in one of two ways. You can either add adrenaline to the noradrenaline, or you can add dobutamine to the noradrenaline. Both of those would have a very similar effect. If you're warm, then it means that you have still got, you've still peripherally vasodilated. So you can then do one of two things. You can then either increase your noradrenaline further to infinitum, which is usually met with progressively less success, or you could add baseline vasopressin. And I think that from a practical point of view, adding early vasopressin in these patients is a good option. Then our last slide is just to have a look at some practicalities around these medications. As you become acidotic, the affinity of both adrenaline and noradrenaline for the receptor decreases. Vasopressin doesn't have that effect, and once again, a reason why vasopressin is a very useful medication for us in patients who are unwell and acidotic. The second thing is lactate with adrenaline. When you start patients on adrenaline, the lactate goes up. So when I was a fellow, the teaching was that the reason why your lactate goes up with adrenaline is because it causes vasoconstriction, and that it decreases the perfusion to your splanchnic bed, and then causes lactic acidosis to result as a consequence of that. But that has all turned out to be untrue, because if you think about it, if you're going to cause, if that was the mechanism, then surely noradrenaline would be a bigger cause of a lactic, an increased lactate than adrenaline would be. And really that was the impetus, and where this story about dobutamine then came in, because people then thought that you would add dobutamine to improve the splanchnic perfusion. Please don't do that. It's not the right thing to do. The reason why lactate goes up with adrenaline is because adrenaline blocks the pyruvate from entering the Krebs cycle. And this was shown in a very eloquent study in a French study with rabbits, where they then gave an escape pathway to clear the pyruvate, and the lactate cleared entirely. So essentially the lactate increase that you see with adrenaline is benign. It doesn't mean anything, but lactate is a useful thing for us to monitor. So we'd like to see that lactate comes down. So when you've put a patient on adrenaline and the lactate doesn't come down, you don't know whether the lactate's not coming down because of the adrenaline or because the patient's not getting better. So it sort of removes a monitoring endpoint for us, which is not the end of the world, but it's just something to consider. Traditionally, adrenaline and noradrenaline are mixed in 6, 12, 24, 48 apps. I'm sure you've all heard of single strength, double strength, quadruple strength adrenaline. The reason why this was done was to allow for easy calculation, because if you take 6 amps of adrenaline into 100 moles, and you take a patient's weight as average weight of 60 kilograms, then you can start working out how many micrograms per hour. Generally would be about 1 mic per hour that you would be giving the patient. Obviously, with our infusion pumps at the moment, this infusion pump would infuse it at the concentration you have, and you can mix your adrenaline and noradrenaline whichever way you want to mix it. There's no reason that it needs to be 6 or 12 amps. And then bicarbonate activates both adrenaline and adrenaline. Please make sure that when you run inotropes in patients, do not share the inotropes with a bicarbonate infusion on the same port on the central line, because then you would just be giving saline or dextrose water, depending on how you've mixed the medication. So it's important that you don't mix bicarbonate with any of these drugs. All right, so that's it. Any questions?